This is after the headlines. I'm Sarzah. Over the past few months, Bangladesh has been facing one of its most catastrophic measles outbreaks in recent history. According to the Directorate General of Health Services from 15th March until yesterday, 575 children have died from measles and its associated complications and symptoms. The surging outbreak remains at a high level and deaths are not yet declining. Currently, we have more than 68,000 suspected cases. On average, more than 57 children are dying every week. Hospital capacities are under severe strain, and yet, compared to the magnitude of the crisis, we're not seeing a sustained critical public conversation about what this outbreak actually tells us about the state of our current healthcare system. What makes this outbreak particularly striking is that Bangladesh has historically been regarded as a public health success story. The country earned international recognition for its immunization campaigns and its ability to deliver vaccines in resource-constrained settings. Measles was widely viewed as a preventable disease that modern vaccination systems had under control. But in recent years, measles has also re-emerged in several high-income countries as well, including the United States and Canada, reminding us that public health gains require sustained investment, institutional capacity, and public trust. That brings us to our central question for today's conversation. What does this outbreak tell us about the state of healthcare governance and public health preparedness in Bangladesh? And to help us explore the current state of public health infrastructure, I'm joined by Sajidan Rafsan, a healthcare innovator, social entrepreneur, and researcher whose work spans across healthcare technology, public health, and systems innovation. He is the founder of Apex Stride Mobility Systems and the Shirin Sajmila International Foundation, SSIF, and is currently leading the development of an advanced medical innovation lab focused on addressing healthcare challenges in resource-constrained settings across South Asia, Africa, and Middle East. His organization has supported more than 700,000 beneficiaries through work in public health, humanitarian response, and community health. Sajidan's work also includes research and innovation efforts connected to the Dana-Farber Cancer Institute and Harvard Medical School. Sajidan, thank you for joining us today.
Thank you, Sarja, for having me. I'm really honored to be in your episode, and hopefully, we'll have a data-driven conversation and try to enlighten the overall catastrophic situation, what's going on in Bangladesh, and how can we, as individuals, overcome this.
Yes, absolutely. That's the goal, Sajidan. Thank you for being here. We are seeing a lot of heartbreaking images and stories of families and children emerging over the past couple of months. Bangladesh has historically been praised, as you know, for its vaccination efforts and public health achievements. How did we get to this point, and how do you interpret the current crisis from a systems perspective?
I think we have always been sort of perceived as the champions in public health, but slowly, I think the infrastructure over the years, especially the period of Army League, I think we slowly sort of had small damages, but we overlooked into them. And I think those small damages like came into the bigger sort of issues right now, what we are facing. But I would like to talk less about the blame game. Basically, a lot of the situation has been politicized by different political parties, different entities, blaming UNICEF, blaming the interim regime, blaming all this, which has made it in sort of conversations so that we can prevent such like outbreaks in future. But because of the blame game, a lot of the public perception has been more on that rather than on the actual sort of situation currently what we are facing. 575 deaths, these are reports by different news outlets, but we also have to understand such death tolls or reporting is unreported usually because we don't get to know about like patients who died without coming to the hospital. So there's one layer of that. Second layer is about because of measles, the problem is the immunity goes low. So a lot of children die because of pneumonia, diarrhea, and other sort of issues. So my estimation is it's almost like probably 2x of what we have been getting the official reports based on different complications, from like reporting from other aspects. And a lot of people don't report as well. So it's a lot more than what we are getting. That's my estimation. And the way it has been like spread across. So even before the Eid festivities, we have had, I think, 62 districts out of 64. And I'm pretty sure after the Eid, because of the transport, because of people like with close proximity being that has, I think, probably even spread more. And I have been using my social media as sort of like an awareness in telling how we have to be more aware before the Eid, because maybe we haven't seen the peak yet.
Mm-hmm.
You never know. With public health infrastructure, the only solution for measles is actually like the delivery of the vaccines. That
Yeah.
has been a proven record in other countries where the outbreak has come before. So I think we have to focus on that. But for that, I mean, I'm predominantly based in US. Even during the COVID, there was a huge US people in general are more informed,
Mm.
as we can sort of we assume that. But like the taboo around vaccines, a lot of people wanted to like leave the vaccine. It happened in Bangladesh and everything, and they have more issues in sort of like, okay, would this vaccine work for us? So like, what are the complications and everything, because of the religious taboo, because of the socioeconomic taboo, those challenges. So a lot of awareness is needed, and I think that sort of brings a collective responsibility from all of us, not just the public health experts, not the ministries, but as well as average person who can spread awareness in their neighborhood and actually get people to vaccinate. So that's like an overview
Yeah.
of what is like happening. Then we can get into the particular aspects as well. Yeah.
Sajidan, you have mentioned very key points over here. One about public trust, taboo about vaccination, misinformation, politicization, and also a very critical point about data. And since you talked about data, I did have a question about data, and I want to get it out of the way. So one issue that we experience a lot during our public health crisis moments is the challenge of obtaining accurately and timely data. So throughout this outbreak, there has been a lot of debate about vaccination, coverage rates, immunity gaps, case counts, scale of the crisis itself. And we often struggle with a fragmented data system and questions around how effectively data informs our policy decisions. How significant is the data challenge in Bangladesh's healthcare sector, and what would a truly data-driven public health system look like in Bangladesh?
Yeah, thanks, Sarja. I think you have brought the most fundamental like issue currently in the public health infrastructure of Bangladesh. It's always been data, because we have been isolated by different. So let's break it down. Like, imagine like a village, a remote village in Brahmanbaria. Those places, remote aspects, they don't really have like internet coverage, or like they don't have a longitudinal data tracking system. It's basically like through ancient methods of sort of getting the data on a like a sort of a document book and getting access by different like health officials, getting it signed. And once it reaches the Dhaka or the central sort of like the system, the data, because it's constantly changing, right? Like with these sort of like outbreaks, it's every moment matters, every hour matters. We don't have a centralized data tracking system where it's all under sort of like a website or like sort of like a system, and it's not available for the public. That's a second sort of problem. So even these like fragmented news, uh, they don't actually like reach the masses that much. We can't replicate exactly what has worked with the data tracking systems in UK or US, because the way our society works is much different from how they have like sort of worked around. But like I think things like a lot of the people actually get awareness in Bangladesh through mosque sermons. It's
Hmm.
like week khutbas and everything. But in predominantly khutbah settings, it has been always like more on the Islamic sort of history and other things, moral lessons. I think it's high time we integrate some of the public health warnings, information, and everything, because people really listen to that for 2 hours, 3 hours. And it is much in line with Islamic lessons as well. So it doesn't go like straying away from what is the essence of Islam. And most of the people, as we talked briefly about the taboo issue, needs to get like household level information that, okay, this is what is the situation currently in Bangladesh, and how do we sort of get rid of it, especially through social media. What I've realized is, so we did two work through SSIF. We sent like different teams to different local hospitals, where predominantly the government hospitals children come for measles treatment. We tried looking in, and it has been chaotic. We went to Dhaka Medical College, we went to Chittagong Medical College. you'd see there's a like dedicated ward, but that ward is not protected that much. So there can be sort of exchange of people, or it's not that protected. We have to understand the reality of Bangladesh.
Right. Yeah.
In Bangladesh, there's one or two wards dedicated for pediatric patients, right? And those are limited. People usually don't even get seat. Let's not even talk about like cabin or like other sort of like protected system. They don't get seat. You would see them like lying down in the near the stairs or outside the hospital. And usually in Bangladesh, we don't have the even patient. Let's not talk about like sort of physician etiquette. We don't even have the basic sense of patient etiquette because we have not been informed, educated. So usually with one child, if that child is affected, 7, 8 family members from the village would come in and accompany. And that sort of creates more strain on the hospital because
Right.
the seats are limited. And like one patient wouldn't stay overnight. So they would be accompanied by different sort of people. So it always, with local health infrastructure, it always creates more and more danger for spreading of the outbreak because of the societal structure we have sort of surrounded ourselves with. So those fundamental things, I think data can fix it, but even data probably can't grasp the whole reality into it. So I think we need a hybrid model. We need to sort of understand the reality deep down of Bangladesh, how the society at root level, family level work, society level work, and then integrate the technology from probably the Western framework and try to create a hybrid model which works well for Bangladesh. I mean, one of the things I really liked by the current government was about the health card system. So many, it actually became a social media troll because those sort of card systems work pretty well in the Western framework. But in Bangladesh, adapting it to the social reality, that hasn't worked well. So kudos to the government for starting something innovative, root level understanding how these things would be perceived.
I do want us to go back to a point you mentioned about trolling when it comes to the health cards. And how much of it do you think is rooted in public distrust in institutions? And as you mentioned previously, that during the previous government era, institutions have been gutted. So the historical aspects really inform this phenomena of public mistrust or distrust in institutions. Given that you've been working on the ground very closely with SSIF and also your lab now, how do you think we can go about building public trust in institutions, especially during such crisis moments?
Yeah, I mean, that's a really difficult question to answer because it's, as I said, the public distrust has somewhat strong justification because of the long Aumili regime. I mean, the reality is when you go to a local health provider, especially in Upazila level or like union level, you can't really get like basic treatment that much. I mean, once it's under somewhat of an understanding of that, okay, they shift to the district level or like to Dhaka or Chittagong level. And so constantly patients or attendants are frustrated with the system. They don't get comfortable enough. And on top of that, since, for example, the healthcare provider ratio with the patient and attendant, that's also very key. So you would see in a local health provider in clinic or like even Chittagong Medical College or Dhaka Medical College, they would have one nurse and then she has to serve a ward of 300 patients. There has been cases like that as well. Few doctors. Doctors would be there until like 11 o'clock, 1 o'clock, then they have to go to private chambers. So the only treatment these patients would get is from 9 a.m. to 11 or 12.
Right.
And so like someone like that's what we have realized through SSIF is that ratio. And on top of that, the etiquette. Basically, this nurse and everything, they have not been informed. How do we react? How do we talk to the patients?
Yeah.
And that sort of creates a natural mistrust, a distrust
Yeah.
that these people don't really care about us. These people don't really care about our health. They're just doing it for the sake of it. So even without the politicization, on top of that, the root level, the mistrust is there. And on top of that, when they get to they hear, okay, these money, a huge amount of funds are getting smuggled. They're not spending much on health infrastructure and stuff. So that creates an overall sort of mistrust. And that probably wouldn't change even after government changes, because that's deep down uh, reality of it that, okay, these things, these systems are not meant for us. And I think that creates a much more of a rift between the healthcare providers and the patients. And there's a deep-rooted societal classism on top of that, because these like from like low socioeconomic background, they believe, okay, these doctors, these healthcare providers come from a higher class, and there's a class divide, the way
Yeah.
they would say names. Like in Bangladesh, for example, when I go as a public health expert to doctors and everything, they call me, even though like I'm like 20, 30 years like age-wise like sort of younger to them, and they would say apni or aap in what the language is. And they would be like people with 40 years, 50 years, 6 years, and they would be named as tui, or like in a very derogatory sort of language.
Right.
So these people like feel okay, they are being dehumanized
Right.
uh, in public health infrastructure wise. So these dehumanization creates much more sort of frustration on top of all these like things. So these are all connected. And I think my sort of vision has always been through SSIF. We connect with doctors. So we say Bangladeshi treatment is actually not that bad compared to the resources, what we have been provided with. Actually, it's the behavior, it's the etiquette, it's the advocacy that has actually made it even worse than it's originally in its form. So I always try to do sessions around it. Okay, how do we behave well and everything? But the reality is, even with these interventions, the reality wouldn't change drastically. It would
Yeah.
slowly probably start some new conversations. So you said about trolling. I want discourse. I don't want irrational trolling. I
Mm-hmm.
want discourse. Okay, how do we fix this? Well, we know all these realities, but what do we do about it? How do we sort of create, like especially after the July Revolution, people have been more vocal, especially the Gen Z, about these things and everything. But I think disproportionately there have been more conversations on politics, on other things, but the root healthcare, uh, like sort of problems and issues and infrastructure, there has been less discourse
They've been
around it. There
sidelined in many ways.
are very, very episodic sort of things. We have always talked about the thing with sort of discourse on Facebook, the predominance is we are very crisis-based platform. We don't have a consistent sort of discourse around things to improve. So if there's a milestone air crash, we talk
Mm-hmm.
about 2, 3 days. We would share populist sort of post that would get more engagement and everything. I was looking at it's not related to healthcare, but I was devastated after the killing of Ramisa Akhtar, the
Yeah.
8-year-old girl, and I was looking at how media is framing the very devastating situation by the father when he was explaining the situation, and especially such like traumatic event, people are not even in their senses to talk about different things, and like how he was demanding the justice and everything. And I was sure from the start that okay, now people are doing okay, we want justice and everything, and government would do it. Probably it would take some time, 1 month, 2 months, 3 months, because there's such populist outreach.
Right.
But what about other people who are not highlighted
Mm-hmm.
in the media? Other like children who are getting violated sexually and other ways. And after 3 days, I was following it. Fourth day, the father comes in, interacts with people from the like opposite sex, and like her like children who went to school with Ramisa. Probably like he was emotional, he was like close with them in proximity. And I've seen pages with millions of following sexualizing it, making
Mm-hmm.
him look like a pervert.
These cases that become sensational, right, because of how the overall media ecosystem portrays it or sort of transmits, that really politicizes the situation, right? And then people are divided into these two camps. And I think that also happens with health news as well. And I think that that is very concerning because it pertains to a much, much larger population. So I want to, touch upon one aspect that you mentioned, and I think it's a very significant one, Sajidan, and that is given the resources that we have, our treatment is actually not that bad.
Yeah.
There is something to be hopeful about. Um, Speaking of resources, you have seen shifts in global health finance. USAID programs in different places have been massively scaled back and affected. World Health Organization funding has come under tremendous scrutiny, and there are broader questions about future of public health partnerships. Given that you are heading SSIF and you've experienced so much on the very grassroots level, how vulnerable are countries like Bangladesh when global public health funding and international support systems become fragile?
Yeah, that's a very key point we should discuss about, because in Bangladeshi public health sort of funding, a lot of the funding is predominantly through NGOs and as well as the government. So, but the reality is with the NGO funding, we are based in US, but we do a lot of work in like Middle East and like Africa, which probably in Africa I would say it's even more vulnerable than Bangladesh. So from a refracting framework, Bangladesh is slightly in a better position because we have a lot of NGOs who have got like exposure to the funding world. But the way the budget works, the way the execution team works, you would say like 10 to 15% of the actual fund goes into the actual work. 70% is more about, okay, getting the offices, salaries by the employees. So the impact doesn't come out that well compared to the funding, what we have been getting. And that sort of creates, okay, like they have mistrust on that level. So we have, I think, less of funding. That could be one of the reasons, because we don't have good. Basically, with the NGO work, you have to show impact reports and actually break down things. And in Bangladesh, the transmission of money, the transparency, accountability, I think deep down is an issue, both at the government level as well as, and top of that, there's corruption and everything, which makes it even more complicated.
Yeah.
So we go back to data again. The data, even the work we have been doing, doesn't come across as transparent. And there's accountability in different levels. That sort of creates less of us an opportunity to grab even more funds from World Bank, from UNICEF, and other levels. So, I mean, I think there has to be sort of some sort of like a union of all these like fragmented healthcare aspects so that become more accountable.
Yeah, absolutely. And speaking of all these different stakeholders in the broader public health ecosystem, Sajidan, we know that UNICEF Bangladesh has been very vocal about what's happening with the outbreak, about warning of declining immunization coverage, growing immunity gaps. Where there are warning signs that our policymakers and institutions could have taken more seriously before this outbreak reached this scale, and what does this interaction with UNICEF and with all other stakeholders really tell about our institutional priorities?
Yeah, as I mentioned before about the social media discourse, same goes with the infrastructure of our healthcare. We are not preventive. We are more crisis based. So once we see the symptoms and it goes really bad in a chaotic way, only then we intervene. So there has been warnings since the earlier half of the year that we have to sort of get the vaccination to all these places and get this 95% sort of threshold so that we have sort of to handle. We actually, I think the public health experts knew what was coming, but they were not paying much attention to how chaotic and how catastrophic it could be. They couldn't estimate probably the devastating effect, how that decision could be. So that sort of exchange of ideas between these healthcare experts through UNICEF, through other platforms, I think we have failed completely in creating that sort of trust between these programs. And then we need visionary sort of leadership as well, who understand the reality and how. I mean, I was just reading one article by US Healthcare Office. They are, since the outbreak has spread all out in Bangladesh, they're concerned in US that it will travel across there. So far in the global south, somewhere in South Asia and in North America, countries is sort of like preparing more on an awareness level and like sort of academic discourse. How do you prevent it?
I mean,
So
same
probably
happening with the Ebola outbreak, right?
Yeah.
The awareness that
So
they're spreading. Yeah.
So it has to be, we have to start 6 months before such even an idea that some sort of an outbreak, not even an outbreak, a somewhat of a complication in a national level might come across. So we need more consistency in terms of decisions in preventive framework, a protocol of how things, like as you said, like this is not just measles. There would be other viruses probably in near future. I think this should be a learning lesson. Then there wouldn't be social media accountability. Before the next outbreak comes, probably a year or two, there wouldn't be any social media discourse. There wouldn't be any accountability or some sort of a reform protest. Okay, let's let's push the government. So the government and the public health infrastructure has to work independently out of populist ideas that before the next thing comes in, we have to fix these realities. I think with different viruses, which are people like Bangladesh is vulnerable to, government should do like a grassroots level sort of awareness and mobilization. They should now focus on vaccination for other like viruses as well, and provide appropriate amount to Buzilla level, union level, then try to create awareness to get vaccination for different things. Children and especially postpartum women and pregnant women, they are vulnerable to these viruses predominantly. I would like to share one like distinct sort of like event what we have come across. So after the July Revolution, I was on ground with SSIF working in different flood-based affected villages, providing relief, providing healthcare advice, and then we are having post-flood camps as well, health camps by different physicians. So what we realized is menstrual hygiene was not taken into consideration in different shelters. Or it's a societal taboo. Even just access to menstrual hygiene kits itself is a privilege, and it's still the discourses around cities, but not in the village level. And on during this chaotic sort of flood level, access to such basic amenities even got reduced. So we were trying to work on it, provide menstrual hygiene kits, and try to provide everything. In the post-health camps, what we saw is probably the places where we were able to provide menstrual hygiene kits for like on a weekly basis, they had less sort of maternal health issues or infections. So, and other places that became even like the child mortality rate in Bangladesh. These things, we always blame the entire like healthcare facility, but these things actually can be fixed with basic facilities, access to basic menstrual hygiene, access to basic sort of first aid. So then unfortunately the mortality rate among the women, among the children, they rise in floods. And that's not part of the discourse. Yeah. Because we only provide okay food aid and everything and like dry food, but the healthcare, especially in Feni was one of the like vulnerable place in 2024 August floods. And in Feni, there's no pediatric ICU facility, not a single seat. There's 100 seats available in their only ICU facility, and they don't have any dedicated maternal health care point. They don't have any, they don't even have what do you call it, the ICU dialysis facility. So people would have with kidney failures and everything, they can't even get dialysis.
That's why people are pushed to come to Dhaka, and Dhaka's healthcare facilities are already under a lot of burden.
A lot of burden, and even in Dhaka, the government ICU facility is limited. There's private like facilities available by different private clinics, but it's completely unaffordable for the majority of the masses who come from outside districts. So we have to think they are not even going to private clinics unless they are taking huge loans or selling their land and everything. That's a different topic. But with the government facilities, it's even worse. Probably to get one seat, people have to wait 3 weeks, 4 weeks. Actually, I mean, it's so ironical that people pray that somebody dies in an ICU facility so that they can swap in some of their family member. It's that bad. Patients are forced when they are in coma or anything.
Sajidan, you may have seen that just a few days ago, right before Eid, 6 infants died at Ad-Din Hospital because of a technical problem. And there's a lot of protest about what has happened. It's devastating. It's heartbreaking. And currently, DGHS is trying to get the investigative report on what has happened. And we see that after every crisis moment, we become very reactive, and there are committees upon committees, investigative reports upon investigative reports, but we don't really see a tangible outcome for victims. If you could touch upon these investigative processes with a particular focus on neonatal care. I remember that you spoke about the limited pediatric care facility that we have. How are we really approaching or prioritizing child health and child protection within our healthcare system?
I mean, these issues have always worked in other countries, the multidisciplinary approach. in sort of like protection of the children, especially events like what happened in the Aldin hospital, as you said. We don't have legal sort of limitations in terms of like providing justice and in terms of providing a solution or like a preventive protocol. But this goes back to the fragmented framework, which I was like highlighting about how these committees, although they should be much more interconnected, they have what we call system loss, basically, like in terms of like time and efficiency. Because what happens is once such an incident comes in, there has to be a GD in like a local police station about what has happened. And for the GD, they need to take testimonies of like different stakeholders, including the victims, uh, parents, or like their family. And then there's a like, sort of like a taboo, or like they are going through such depressive state
Right.
in terms of like sort of cooperating in a way. It's hard for them because we don't have a sort of like we don't have a system where we could provide comfort and counseling. Because especially in the Western countries, when we try to investigate such stuff, we have an attorney right away with us who cooperates with the victim's family. And they give them the sort of, okay, you don't have to do all this, but it would be better for the justice providing. And they try to console mentally and help them out in becoming comfortable with this like very like strenuous sort of and very frightening sort of like justice framework we have got. We don't have that, and we don't get the testimonies on time. And then these, even if you get the testimonies, these are then recorded in police stations, and then they have to like send to different parties. If it's like a case in the public hearing, then that's a different process. Then it has to sort of get signed by different stakeholders and by the healthcare office, by legal teams and everything. And then to like to hold it accountable, public outreach protests would continue for a day or two, highest. That's how usually it works. But in the end, who stays with the system is the victim's family.
Right.
And on top of the devastating framework, a devastating state they are in, they also need to be financially involved in the process as well.
Yes.
For a long time to sort of cover the litigation fees, to cover the attorney's fees and everything. And that takes a while as well. And with these hospitals, constantly I'm trying to put who are the victims in Bangladesh. It's not always the elite social economic class. It's a low socioeconomic background.
Yeah.
These families have day laborers. These families have rickshaw pullers. These families work in the construction. And for them to continue with all this on top of these legal processes, they give up. And then we can't really protect our children.
Yes.
Because the system is low, people can't take care of it themselves, and then they just say, okay, whatever happened, probably we deserved it, or probably it's the system, and they leave it. And honestly speaking, I don't see any like rational sort of like irrational sort of like understanding of this, because it's the reality. Like we can't really support these families. Some NGOs provide legal aid at pro bono services, but they are limited. And even though if they are not limited, the access to those NGOs, that itself is a problem. Like not every hospital would give them the advice, would give them the access to such NGOs. So it's altogether like very fragmented, these processes, and it doesn't really help the patients. It doesn't really help even the investigators. It doesn't really help the government.
Yeah.
And all of us fail in a cumulative way.
Right. Sajidan, in one of your news articles, you had mentioned something that really stuck with me, and that is you want to make your foundation obsolete because systems should be independent or fulfilled enough to be able to carry best practices forward. That, you know, those best practices shouldn't be dependent on the work of one foundation or one person. So from that angle, I want you to speak about what meaningful reform or preparedness could look like after this crisis, and what are some of the long-term lessons Bangladesh can draw from this experience.
I think Bangladesh should focus less on procurement. We have already procured a lot of vaccines. That's an easier channel for the government level. You can ask companies, you can ask big NGOs. UNICEF, they would be providing the vaccines. It's more about the delivery.
Mm-hmm.
How do we get to the remote isolated villages? How do we get more transparent where public outrage can be limited?
Mm-hmm.
What we have done, I mean, I'll go back to the menstrual hygiene example I was giving you. We tried, so a lot of the female volunteers wouldn't cooperate in such chaotic, because of the societal structure, families don't allow female volunteers with NGOs going in these remote villages, because we can't really sort of have a protective for these ones. So once male volunteers, different temporary shelters, there's a backlash. That's what I realized. Like these families, because of the Islamic sort of protective sort of framework, or in general, like taboo, they wouldn't allow male volunteers to come in and give advice, those things which we don't talk about much. We had to face severe backlash. Even like volunteers got beaten up, got injured, where they said like this framework wouldn't work in Upazila level. So we have to, by obsolete, I just don't always mean even after I die, ocean should exist. It's how we put the local people at the forefront of this delivery.
Absolutely.
Like how they should be the leaders. We are more of the logistical support. And how, so since then, we have tried working with local volunteers. So whenever we go, we try to intervene. We don't try to bring our own, we don't try to impose our own solutions on top of their face. We want to understand their framework, their societal structure, and collaborate with them and bring the solution. That's much more effective. That's much more durable. And in a macro level, I think Bangladesh should do more workshops, training of, especially with maternal health care. I'm doing a project for Peace Project that handles that sort of understanding, is midwives or local healthcare workers. They are not trained much in a macro sort of level in all these districts, because a lot of the women, especially pregnant women, they prefer midwives over the healthcare sort of workers in different clinics. That's still the reality of Bangladesh.
Yeah.
And a lot of the mortality rate is rising because they don't have trust in healthcare workers, and they don't have trained midwives who have the high efficiency or technology, so to sort of cooperate with different complications coming in. So I think Bangladesh should focus really on the fundamentals of the system, where each voice is heard and proper training and workshop is given to different stakeholders, not just doctors. And that's how we create different focal points in different villages. Youth, they understand the complication. Mothers knows, have an understanding, okay, this is how, for example, the cartoon Meena. I think that was I would say a huge success at the grassroots level, in terms of they provided awareness in a way which is comprehensible for these masses. So with the public health infrastructure, how it's hailed as one of the success stories globally of Bangladesh stems from such interventions by the government, like Meena Project, where that cartoon got massive sort of popularity among the masses, and it was compatible, it was palatable with the masses understanding, and it created more societal level understanding of different gender-based justice and everything. I think with public health infrastructure, maternal health care, neonatal care, those things, which I think is the most vulnerable sectors in the healthcare infrastructure of Bangladesh, more such interventions has to be made by the government. And on top of that, training workshops for midwives, for youth, for awareness for postpartum and pregnant women. These things we would work on, not just isolated projects. A lot of the things which people take seriously are the religious leaders in these local villages. We have to integrate them into the discourse. We have to integrate them into the discussion. I briefly mentioned about the khutbahs. In the khutbah, we have to integrate the Islamic essence, how healthcare works, or in general, system level have worked by Prophet, peace be upon him, sallallahu alaihi wasallam, and his sahabis, and integrate the hadith literature, integrate the Quranic literature into this. I think that most of these taboos would go away, because then people would relate, because Bangladesh are very faith-based sort of understanding of different things. Once they scholars, I think people like Ahmadullah, Islamic scholar like Ahmadullah, and other scholars like Mizanur Rahman Azari, they should come in, integrate, and they should be part of the ecosystem as well. Then the union parishads should be part of the ecosystem as well. I want these discourses to happen in just in Idgah, but once they go in 5 times They would discuss problems, healthcare problems in the local level, and how do we integrate it?
Absolutely.
That could be a way government can actually fix a lot of it, because then infrastructure is already there. We are just not considering it into our public health infrastructure.
Yeah, I think over here, what I
We have
hear from you, Sajidan, is that we do really need to think out of the box over here and really contextualize
Yeah.
our problems and how we connect with each other and sort of use our local ecosystem to drive our efforts. I really want to thank you and thank you so much for helping us think through these really critical issues. And what I hear from this conversation is that the public health crisis, it's often the result of years of accumulated decisions and indecisions, investments and missed opportunities, and institutional decisions. And if there is one lesson from this moment, it may be that healthcare should not only become visible when there is an outbreak or when there is a systemic failure, because we see that the strongest healthcare systems are often the ones that we barely notice because prevention is working, vaccinations are reaching children, hospitals are prepared, and crises are stopped before they become national emergencies. So really appreciate your thoughtful insights, Sajidan. Thank you to the listeners. If you found this conversation valuable, please share it with others and uh, see you next time.